Most respected chairperson, thank you, sir, for the nice introduction. And most respected senior members of the Association of Physicians of India West Bengal chapter, which has traditionally been the mecca of clinical medicine, and also the founding fathers of the Global Cardio-Diabetes Conclave and Indo-Global Cardio-Diabetic Academy. I consider this as a special privilege for being invited and giving me an opportunity to speak in front of you. In fact, these are some of the thoughts which I would like to share about the non-invasive evaluation of diabetic heart disease. A warm greetings from my department at the Tamil Nadu Government Multi-Super Specialty Hospital from my staff. And these are some of the points which we already know of. Professor A.K. Banerjee, in his elegant oration, he has stressed upon the rising trends of the prevalence of diabetes, especially the type 1 and type 2 diabetes. We can optimistically think that it is predominant, possibly due to the advancements in the investigations and the management strategies. The statistics often say that number of diabetes are increasing, but then the people are living longer. And diabetes is always increased with twofold increase in coronary artery disease. And in the combination of stroke, it is fourfold increase. Early diagnosis is very important. Even in the because of the various comorbidities, we should be able to identify the subclinical stage itself. And we have seen that, the invasive coronary angiography still remains the gold standard. We can see a resolution of about 0.2 millimeter thickness. There are other amazing strategies we'll be discussing about, which will be giving their own complementary information about the management of diabetic heart disease. So what is diabetic heart disease? It indicates that it is a presence of an abnormal myocardial structure and function. If there is abnormal myocardial structure and function in the absence of the usual risk factors like atherosclerosis, hypertension, valvular heart disease, dyslipidemia, obesity, all these things are absent, still the myocardial abnormality is persistent. And it is more common in women. It is 5 times more common in women than in men, and is predominantly it is subclinical. And there are multiple metabolic pathways that are involved, which ultimately first leads to diastolic heart failure, then it leads to systolic heart failure. There are various pathophysiological processes involved. Our previous orator has discussed in elaborate, and which causes apoptosis and cell death. This is how it is. There is hyperglycemia, insulin resistance, hyperlipidemia, thyroid dysfunction, which causes cardiac insulin resistance and various metabolic disorders, which upregulates the inflammatory mediators, which causes microvascular disorders. Cardiac stiffness increases, diastolic dysfunction happens, there is hypertrophy, fibrosis, and when the dysfunction persists, it causes systolic dysfunction, and finally the cell death. So actually, this is what it is. There is altered myocardial metabolism. There is glucotoxicity and lipotoxicity increases. There is intestinal fibrosis, endothelial dysfunction, and diabetic macular disease and coronary atherosclerosis. This causes the change in shape of the LV itself. From a potato-shaped heart, it becomes more a tomato-shaped heart. And we can see that the non-contractile, the base of the heart, it has become more prominent. And the geometry is altered, and the circumference is shortened. The circumference is lengthened, which causes failure. As a consequence, what we do is, there is a shift in strategy how to manage the diabetic heart disease. Previously, we were more interested in maintaining the euglycemic level. And then, nowadays, our strategy is to minimize the cardiac risk and identify the other comorbidity factors. And the presence of diabetes itself, it increases the 10-year cardiovascular risk in more than 20% of the patient in non-diabetics. And in a big study, which in a meta-analysis, what it says is that people with diabetes without prior MI, there is lower risk of diabetic coronary disease. This is something which is quite interesting. Perhaps because people are being subjected to repeated medical tests, and they are because of the increased awareness, lifestyle modification, the risk of developing CHD is decreasing. And there is extensive debates how to manage whether to routinely screen the diabetic heart disease or not, about the economics involved. But then screening is definitely helpful for any subclinical disease. These are the imaging strategies. And what we commonly use is non-invasive imaging study, the CT coronary angiography, where we see the structure and anatomy. Then the MR imaging, we see the structural as well as anatomy. The radionuclide method, where we see the blood within the ventricle alone. We can see the various segments of the ventricle, whether it is contracting in synchrony or asynchrony is there. Then we have the cardiac SPECT. We see the myocardial perfusion imaging, where we can see the three-dimensional depiction of the heart. We can, the orientation of the ventricle can be modified. We can cut the slices of the ventricle into 2.7 millimeters thickness. We can evaluate how each slice is contracting. The same applies to the cardiac PET also, where we use different set of tracers which are which emit positively charged electrons or positrons, which exist only for a few seconds to a few minutes. It helps us to dynamically image the various metabolic processes involved. Then we can see the neuroreceptor distribution of the heart with MIBG imaging. And these are the various relativity, sensitivity, specificity, the various imaging strategies. What happens is there is increased risk in CT coronary angiogram. One CT coronary angiogram gives more than 750 to 800 chest X-ray amount of radiation. Whereas even though, but in nucleus cancer it is less. In previous days, this particular strategy was not available, but in a city like Kolkata, it is very extensively available, and as a physician, we are required to, we wish we can make use of this imaging method more frequently. That gives us more amount of information and makes us more confident in the patient management. There are other strategies like the transesophageal echoes, which help us to diagnose infective endocarditis, the severity of the valvular heart disease, then intracardiac stents, prosthetic valve evaluation, and the cryptogenic stroke studies. Then the cardiac MRI, where the cardiac hypertrophy, arrhythmogenic right ventricular cardiomyopathy, infiltrative myopathies, all these things can be used. But in a patient with heart failure, the problem is it takes a long time. So for the patient to lie down in a supine position, some of the strategies are quite difficult. So we have to optimize what is best for the given patient, the given clinical condition. Just to give an idea, this is the radial label we use in nuclear cardiology techniques, and which is only a clear transparent liquid. We use, if you want to measure in weight, we use 15 to 20 micrograms or nanogram level substance, and that emits invisible radiation called as the gamma rays. And this is tagged with a carrier molecule called as a radiopharmaceutical. Very little amount of tracer is injected, goes to the target tissue, this is the myocardium, and we use sophisticated equipments, and this is how the images are generated. We can stress the heart by either by physical method, by making the patient run on a treadmill or isometric hand grip, or by pharmacological methods. Then we have dobutamine, then we have chronotropic agents like atropine, and then we have adenosine, which causes vasodilatation. Dipyridamole can also be used. But in our day-to-day practice, in our center, we are using adenosine very extensively, because the 6 to 8 minutes, the entire protocol is over for us. And by and large, it is relatively safer for the patient, especially for a patient who is old, unwilling to exercise, or the patient who have amputation and other physical disabilities to exercise. This particular strategy helps us to bring out a subclinical heart disease. These are the tracers we are using. The system maybe is the one which are very commonly used, and it goes into the mitochondria. In a normal myocardium, it is rich in mitochondria. In ischemic myocardium, the mitochondrial number is reduced, whereas in infarcted myocardium, the myocardium is replaced by fibrous tissue. There is no mitochondria. As a consequence, the tracer uptake does not happen in that particular region. We also use FDG, fluorodeoxyglucose, glucose, to study the altered glucose metabolism, especially in the myocardium, where the myocardium shifts to glucose metabolism. And we use for neuroreceptor imaging the meta-iodobenzylguanidine. This is how it looks like. What happens is, this is a short axis views, horizontal long axis and vertical long axis. What happens is, this is at 12 o'clock position of the anterior wall, 9 o'clock is the septum, 6 o'clock is the inferior wall, and this is the lateral wall, 3 o'clock is the lateral wall. What we are seeing is the anterior to septum, there is a huge big perfusion defect, and it is getting, during rest images, it's getting reperfused. If there is a degree of reperfusion, we call it as a reversible perfusion defect or ischemic area. And this is what it is. In the anterior wall also, in the corresponding, and the horizontal reconstruction also, in the corresponding images, we are getting the perfusion defect, which are getting reperfused. On the other hand, this is the inferior wall, where the perfusion defect is persisting both the stress and the rest images, and in all the projections, all the slices, and this is an infarcted tissue. And this is the only strategy that helps us to understand the myocardial stunning and the hibernation, and the myocardial hibernation. Both indicates there is a viable myocardium. Only difference is in stunning, the contractile activity resumes after a period of time. We can't predict when the contractile activity can resume, but then it will be able to help objectively evaluate where there is stunning happening. And in the system BB scan, we see the myocardial ischemia on the anterior and septum wall, like a study which was previously there. Whereas when you use fluorodeoxyglucose, FTG PET scans, we can see the ischemic myocardium taking up more of glucose. So here there is a discrepancy where it is. When the ischemic myocardium switches over to glucose metabolism, whereas the normal myocardium is the fatty acid metabolism, you will be able to demonstrate more in the myocardial perfusion studies. And this is the time taken for the tracer when it is administered in the lower limb. Almost within a minute, the entire body is perfused. This is how it looks like in a PET scan. And also, we use a tracer called as rubidium-82. We'll be able to bring out the dynamic perfusion changes. We can, even though the images look deceptively normal, when the ischemic segments, global ischemia persists, the coronary flow reserve is very less. When the CFR is very high in the normal myocardium. So we will be able to objectively determine how much amount of tissue per gram of myocardial tissue per minute per ml, how much amount of perfusion that is happening over a period of time. That helps us to identify objectively. And in the presence of diabetes and heart disease, we can see that the mortality rate is very high. And whether it is heart disease or not, in the presence of diabetes, diabetic itself, when the CFR is less than 1.6, we can see that it's high. Whereas in the CFR is less than greater than 1.6, the mortality is less here. Especially in women in imaging, the breast attenuation causes a lot of interference, and this particular tissue we are having multiple strategies how to overcome the breast attenuation. We'll be able to find out the myocardial perfusion changes non-invasively. And these are the various sensitivity specificity parameters. And what we see is the routine SPECT images, the sensitivity and specificity high, and the PET images, the specificity high, which means that if the test is normal, it virtually rules out coronary artery disease and diabetic heart disease in a woman. And this is something new that is happening. We are going to hear more about flupridase, which is undergoing clinical trials, which is being extensively used in the West. It is yet to be used in our country. And this will help us to more objectively, more clearly bring out the myocardial perfusion that is happening when we compare to the system images, what we routinely use in our clinical practice. These are the list of new cardiac imaging tracers which are going to be talking about in the future. We will be talking about in acute coronary syndromes, we will be using the FDG, fluorinoxine labeled FDG, that brings out the ischemic myocardium, and then which binds with the mitochondrial transporter G180, then pentoxifer, dotatate, all these things can be seen. This is the only modality which helps us to find out vulnerable plaque. 60% plaque may be vulnerable, whereas 90% plaque might have been organized, which has a lesser risk of rupture. All these things can be brought out in this. Then myocardial apoptosis by using annexin. This is a well-established tracer. Then we have microcalcification that can be visualized by sodium fluoride imaging. And then dotatate imaging, which is available in our several centers, which helps us to find out the macrophages, somatostatin receptors, and then the response of the myocardium to chronic chemotherapeutic agents that can also be visualized. So which modality is superior? Way back in 2009, 2013, various recommendations came up comparing one modality with the other. It finally turned out like comparing apples with oranges. Each modality has its strengths and weaknesses based on the imaging strategies in a given clinical condition. So then the recent guidelines are shifted, which says that in the given clinical condition, we may have to use multiple modalities, and a combination of modalities will be able to bring out a better sensitivity and specificity. No single modality is more superior than the other. But still, the invasive coronary angiography remains the gold standard. These are the various strategies which are helpful for revascularization, understanding the revascularization of the myocardium, whether the presence or magnitude of stress-induced ischemia, cellular dehydration of the viable myocardium, the degree of LV modeling, timing and success of the revascularization procedure, adequacy of the target coronary vessels. This is what our previous speaker has been discussing in elaboration. And what you have to understand that nuclear imaging strategies help us to bring out when the perfusion abnormalities happen in the very beginning stage itself. When the diastolic dysfunction persists, then echocardiography and MRI steps in, followed by systolic dysfunction, then the ECG changes, then clinically the angina manifests. So long before it can clinically get manifested, this strategy helps us to bring out the coronary, the diabetic heart disease. Then whether PCI or CABG, whatever it is, we have evidences which say that definitely both the strategies help in the improvement of the quality of life. And also, the patient with non-fatal MI, we prefer optimum medical management because extensive interventions may further decrease the quality of life. This is to work out a strategy how to go about it. When you do a nuclear perfusion study, when the EF is more than 30%, if the sum difference score is less than 2, then we go for optimum medical management. When some difference score is between 2 to 7 or 7, when the EF is about 20 to 50 to 30%, we call it as an intermediate risk, and we go for coronary angiography. Whenever there is an obstruction, then we go for revascularization or optimum medical management. If it is less than 30%, it is very high risk. Let us not waste time on all the other imaging modalities. Straight away go for invasive coronary angiography, map out the obstruction, and then we go for optimum medical management or the revascularization strategy, depends upon the patient's requirement. To sum up, the cardinal features of diabetic heart disease is it includes cardiac stiffness, cardiac dysfunction, myocardial fibrosis, hypertrophy, diastolic dysfunction, systolic dysfunction. And non-invasive imaging tools helps us to detect atherosclerosis, detect the coronary artery disease, whereas the functional studies help us to find out in the subclinical stage itself. In general, depending upon the local expertise available, like for example, and also the strategies vary depend upon the operator. In case of an echocardiogram, a person who, like me, who have less experience in it, we may be able to give a higher estimation, maybe 80 to 90%, sometimes 103%, 110% echocardiogram, because in a hyperinflated lung field, it is very difficult for me to find out the papillary muscle intervention, insertion. Whereas a more experienced echocardiographer can give as good information as a coronary angiogram. And the stress MPA will be able to refine the risk estimation in asymptomatic diabetes patients. And routine screening is whether it is being contemplated in several studies, but in our clinical experience, we find that it is definitely helpful in a diabetic patient. So this is where you are proceeding. Every strategy is advancing with the refined advancement in science and technology. The MRI uses extensive gadolinium double DTPA strategy to find out the myocardial perfusion. Then copper 68 level, technetium 98, indium 111. These are the studies with tracers which are using in nuclear strategies for understanding the viability. Then we use certain tracers which use beta emitters to knock off the abnormal DNA long before it can give a wrong signal like cardiac amyloidosis, heart failure, all these things could be manifested. And then we have the fluorescent probes to find out the receptor protein level estimation. So many developments are happening in various fields. It is often very difficult to catch up, but then as a practicing physician, we are expected to know a bird's eye view of everything. So thank you very much for the great opportunity, sir.
That was a wonderful discourse on the non-invasive management of our diabetes and heart disease. Any questions from the audience, please?
Prabhu, I think an excellent, lot of new information has been given from your side. Coming to clinical perspectives, we are clinicians actually, otherwise asymptomatic diabetic type 2 with some risk factor stratification. There is always a question of whether to investigate these patients, particularly CT, etc., CT angio. Sometimes CT angio is prescribed. You see, CT angio, coronary angio is prescribed. And when there is some problem, again, invasive angio.
Yes, sir.
So I think it's perhaps something which is somewhat a cost, it's not cost effective at all.
I agree with you.
So CT angio has become a, and what is your impression about the coronary artery calcium score, CAC score, I think sometimes can be done. About your last presentation of this ejection fraction 30%, above 30.
Yes.
Do you think that you are satisfied with 30% ejection fraction below and above 30% optimum medical therapy? Say as for example 30 to 40 ejection fraction. Will you be satisfied with your, without any ischemic evidence, with your optimum medical therapy? It should be 30% or it should be 50%. We are all happy when the ejection fraction
EF
is
is about 50, yes. So I will take up in two parts, sir. The initial component, because of easy availability of the expertise, there is less operator orientedness. So we prefer CT angiogram, and CT angiogram gives a more anatomical resolution. Not only the anatomical resolution, we will be able to identify the structures above and below the heart, the relation of the heart to the various surrounding conditions, various tissues in the chest, the organs in the chest. All these things can be done. That what really happens in the presence of heart failure, so we forget about the degree of perfusion that is happening in the kidneys. We forget to monitor the EGF for estimation, the raising serum creatinine levels, and we inject a dye which is about 70 to 130 ml. It really challenges the kidney function. It further deteriorates the renal function. Then, having found out there is a low venal obstruction, then we have to map out which coronary arteries are more severely blocked and where exactly the block is. Then we prefer in a coronary angiogram. We have to inject a little more amount of dye, and which still further deteriorates the renal function. So I feel that CT angio as a strategy for evaluation in patients who has developed symptoms and other comorbidities, it is not really acceptable. In a patient who has come for a routine screening in asymptomatic patients, considering other biochemical parameters are quite normal, CT angiogram can be done. But then what you are really concerned with the amount of radiation exposure, especially with women, when they are exposed to intense amount of radiation, the breast tissue gets exposed. In fact, when we were discussing the other day with our AERB officials, they are alarmed in the sense the CT angiogram gives almost more than 750, 800 times the chest X-ray amount of radiation. Despite of several technologies that are developed, what happens is, instead of taking continuous X-ray emission, they go for intermittent X-rays. In a fraction of a second, multiple beams are shot. So the different radiation limiting strategies are being adopted. In spite of this, the radiation exposure for a patient remains high. And regarding the calcium scoring, the tissue calcification happens where there is persistence of ischemia, persistence of fibrosis, dystrophic calcification happens. So by the time the calcium scoring happens, the calcium deposits happens, the tissue damage is further, it has permanently set in beyond the revasculable, salvageable stage we have reached. Whereas in nuclear imaging, the degree of radiation is less. And we are able to find out pathology. We are trying to understand the pathology long before it can get clinically manifested, be long before an anatomical disease sets in. So this is wherever the technology is available, this has to be more extensively used because the physicians can be more confident about what they are handling. And in the second part of it, I would like to recapture, sir. What is the second? Ejection fraction, why 30%? It is purely arbitrary, sir. We have been receiving patients from the people who do a lot of they use this oxygen scavenging agents that oxymed hospitals, neomed hospitals, they are using a lot of patients, they are using a lot of scavengers, infusions and all. And we have been seeing patients who come with 15%, 23% EF, and they have been living for more than 5 years with the new method of management of heart failure. In the recent American Heart Association, they are also under evaluation of whether such agents can be used for the management of chronic heart disease. So that is also under contemplation. But I really threw up an arbitrary figure regarding the 30%. For all practical purpose, especially in cancer chemotherapy therapy and all, we give large amount of dose till the EF is about 50%. The moment the EF reaches about 50%, we stop giving chemotherapeutic agents, cardiotoxic agents like adriamycin, and then we allow the patient to recoup. When the EF improves, then we will be giving the chemotherapy once again. Whereas this I put it deliberately because it is an arbitrarily defined figure, sir. Anything between 50 to 30, we just take it as an intermediate risk.
Another short comment about your diabetic heart disease.
Yes, sir.
Particularly lot of I think diabetic cardiomyopathy. We are not finding this terminology diabetic cardiomyopathy in the textbooks. And they are saying that mostly it's vascular, either macro or microvascular.
Yes, sir.
So, is there any comment from your side on this?
Obviously, sir. I also fully agree with your observation, sir. It is predominantly vascular. And also we are seeing increased incidence of sarcoid, cardiac sarcoid, especially in diabetic heart disease. Probably it is autoimmune also. That is.
Thank you.
Since we are running short of time, I would like to thank Dr. Prabhu for a wonderful presentation, and I'll hand over the mic to my